Okay, I think we'll get started. Welcome. My name is Kristen Nessenson. I am the Director of Community Relations and Fundraising for the Histiocytosis Association. Before we get started with today's Focus on HLH webinar, I would like to briefly go over a few housekeeping items. Most importantly, this webinar today is for informational purposes only. It is not meant as a medical consultation. We encourage you to speak with your medical team about your specific circumstances. We will be hosting a Q&A following the panelists' presentations today. However, due to time constraints, we may not be able to answer all questions. Please know we will follow up with additional information wherever possible. Also, the webinar is being recorded today. We will provide the recording to you in the days ahead. Also note, participants are muted. As I mentioned, we will be hosting a Q&A with our panelists. To submit your questions, you're going to use the Q&A feature in the webinar panel. So you'll see Q&A. You'll click on that option on the toolbar, and it'll open a window on your screen. You'll type your message to submit a question. Before submitting your question, we ask that you check to see if someone else has already asked the same or a similar question. If so, you can upvote this question by clicking the like button. This will show all of our panelists the most popular questions first. You'll also note a chat window. Today, we're going to use the chat window for this webinar to answer questions that may be posed by the panelists. You can also seek help in there from the Histiocytosis Association, or you can feel free to email me, Kristen, at outreach@histio.org if you're having any difficulties during the webinar. First, I would like to check out the chat feature and make sure it's functioning for everyone. So if you would, just share with us where you're viewing the webinar from today. And I'll just give it a couple seconds to make sure that it is functioning for everyone. Okay, it looks like it's working. We have Minneapolis, New Jersey, Arizona, San Antonio, Texas, Michigan, Ontario, Canada, Washington. Great, so it looks like it is working. Welcome to everyone. So with that, I'd like to turn the program over to your host today, Deanna Fournier, Executive Director of the Histiocytosis Association. Deanna?
Thank you, Kristen. Welcome to the latest webinar in our Histio Patient and Family Educational Webinar Series. Today's focus is on HLH. Our webinar is dedicated to HLH-specific discussions, and we are pleased to welcome a series of experts in this space today. In order to ensure that everyone is able to share in the experience, Kristen ran through a technology overview, and we'll be doing a brief background of our esteemed panelists. I'll then turn the presentation over to our 4 physicians from various institutions who will be leading the remainder of the call today. We are joined by over 75 different households. As Kristen mentioned, you're muted by default. However, please, we encourage you to connect with us through the chat feature and pose questions in the Q&A as well. We'll be actively monitoring both spaces and can respond if you need any help. We'll save time at the very end to go through all the questions that are asked, so we encourage you to ask throughout and know that we'll save that time at the end to ensure we get to all of your questions. Okay, so today we have 4 esteemed physicians, and we'd like to introduce them to you. We have Dr. Carl Allen, who specializes in hematology and oncology from Texas Children's Cancer Center. Dr. Edward Behrens, rheumatology from Children's Hospital of Philadelphia. Dr. Melissa Hines, critical care from St. Jude's Children's Research Hospital. And Dr. Michael Jordan, immunobiology, Cincinnati Children's Hospital Medical Center. So to start us off today, I'm going to turn the presentation over to Dr. Carl Allen.
Okay. Well, thank you so much for the opportunity to join this conversation about HLH. And I think that you see from the range of disciplines that the panel represents that really HLH crosses a lot of different disease disciplines, and we all bring our different perspectives. So I'm going to share mine with you, and my colleagues are free to agree or disagree with me downstream. So a question I often get is difficulty in managing HLH is really compounded by the fact that not everyone really agrees on what HLH means or what it represents. And, I think that to summarize the next several slides, my bias is that HLH is a syndrome of extreme inflammation that can come about from a variety of different causes. But I'm gonna provide a framework for us to discuss this a little bit today. So first of all, I present the zebra here because in medicine we talk about, if you hear hoofbeats, it's probably a horse. But I think in the case of HLH, people are thinking about the more rare things, like could this be HLH or something else? Next slide, please. And one of the criticisms we sometimes get when we're evaluating these patients, when we go to the ICU or other settings, is, if we're a little zealous about looking for HLH, be accused of saying, well, no, this is really just sepsis. This is something more common, but it just looks like a zebra. So, when is something common that looks like HLH, or when is something really HLH? Next slide. And then we sometimes get asked the question, do you believe in HLH? And it's the only diagnosis I'm ever asked a sort of faith-based question to opine on. And I think that it's sort of interesting. And I think what's implicit in that question is that people consider HLH to mean sort of different things. And so again, I'm going to spend the next few slides talking about, I think, a framework for this. Next slide. So I think quite simply, we think of HLH as a syndrome, and why is it important to define HLH? It's not really just an academic question, but I think has massive clinical implications. So approximately 50, now probably more than that, probably 50 to 70% of patients who meet clinical criteria and are treated have a chance at survival, where fewer than 10% of patients with HLH who go unrecognized will likely die from their disease. And the majority of deaths occur in the first 8 weeks, making the ability to identify these patients very, very important. Next slide. So how common is HLH? I think when we talk about epidemiology, it's really difficult because it really, again, it depends on ethnicity, it depends on exposures. I think there's a lot of provider bias in looking for HLH or thinking about what it might be. There's institutional culture. And then when you look at some, ICD-9 refers to the medical coding. So if you look at the medical literature, it can be coded as a lot of different things. So it's very difficult to do chart type reviews. But we estimate it's about 1 in 1.5 million live births. And here at Texas Children's Hospital, we did a chart review and found that about 1 in 3,000 of our hospital admissions ultimately were diagnosed with HLH. That represents about 25 to 30 cases a year at a very large children's hospital. Next slide. Sorry, just go back one more. Oh, there we go. So I think this shows that it's also difficult to estimate how common HLH is because the awareness is really changing. And you can see the blue bar represents sort of all the articles published on HLH in the last, in a given period of time. And so you see that there's just exponential rise in the number of cases and even more exponential rise in the number of adult cases. And so I don't think this represents a new pandemic, rather just sort of a people recognizing this entity. Next slide. So if you think about, well, where did this all come from? I think sometimes it helps to go to the beginning to try to understand why do we think the way we think. And if you go back to the 1950s, there was a series of siblings that turned out to have what we now call HLH. The first case, a child was 9 weeks old who just became acutely ill and died. Next slide. And some very clever physicians noticed that his sister presented with the exact same presentation a year later. And they were clever enough to give some steroids and in fact prolonged her life several months by giving immune suppression. Next slide. And so I think as more and more of these cases were observed, groups at the Histiocyte Society and others tried to kind of put some criteria to figure out how do we characterize these patients. And so in some of the first clinical trials, the HLH-94 in 2004, the Histiocyte Society came up with diagnostic criteria to be able to be considered to have HLH to be treated on those protocols. These are now kind of used as the de facto diagnostic criteria, although they weren't really initially intended to be used that way. And so it's the common things that you're all aware of. So fever, a big spleen and liver, bone marrow function is impaired, can have increased triglycerides, decreased fibrinogen, hemophagocytosis, which I'll talk about in a second. Ferritin's a marker of inflammation that's elevated, as well as a T-cell marker, IL-2 receptor alpha, and then natural killer cell activity is decreased, or you can have inherited disease. Next slide. So hemophagocytosis is what the name comes from. It's not really specific or sensitive for HLH, but I think it's important to understand what it is. So it's when sort of your macrophages, which are sort of the garbage trucks of the immune system, stop recognizing rules of personal space, and they start consuming lymphocytes or red blood cells or other cell types. And so the cells just look kind of angry and vacuolated. Next slide. And so I was working with Mike Jordan and Lisa Filipovich. Our groups were trying to write a paper about how to approach HLH back in 2010. And Mike came up with a really great framework that I think really makes a lot of sense that I continue to share on his behalf. And I think the way to think about HLH is you can be born with something that predisposes you to HLH. So your immune system doesn't quite work right. You have some kind of genetic defect, some kind of family history. And then that manifests itself in some kind of symptoms like fever, increased spleen size, elevated ferritin, et cetera. But then that increased immune activation leads to what we call immune pathology. So your bone marrow is affected, your liver is affected, et cetera. And it's sort of a constellation of those symptoms that make up the diagnostic criteria. Next slide. And so really it depends on sort of the stage of life and maturity of the host, as well as the immune challenges that people run into. I apologize for the background noise. It sounds like our liquid nitrogen tanks are being changed out. Anyway, next slide. So let's talk about the host very briefly. Next slide. So when we talk about the host, it sort of depends on whether you have familial versus secondary HLH. So presumably familial means you've inherited some sort of gene defect, where secondary tends to refer to some kind of immune stimulus that's so strong it drives HLH. This isn't really a clinically helpful question in the acute setting because anyone meeting clinical criteria for HLH is at high risk for death until you remove either that immune stimulus or you replace the immune system with a healthy one in the case of people who have immune defects. So we really consider, at least clinically, all HLH as HLH in the early period. Next slide. And I think that it's really important to understand this concept when you look again at these Kaplan-Meier curves. You can see it's sort of the probability of survival over time, and you have this very steep risk of death for both patients with known inherited HLH as well as people without an obvious cause for their HLH. So it's important to really approach these patients in the same way, regardless of whether or not you suspect an inherited gene defect. Next slide. And so what are these inherited gene defects? So basically, whenever we get an infection, we have antigen presenting cells take up that bacteria, virus, fungus, whatever, and it presents to the effector cells, the NK cells or T cells, different antigens. And so when a cell is recognized as being infected, you can see from this cartoon in the green cytotoxic T cell or NK cell, there's this sort of series of packaging sort of bullets that then go and you punch a hole in the target cell and you shoot those cytotoxic bullets into the infected cell. If any of these steps on that pathway are dysfunctional, you lose the ability to kill target cells, and that's what leads to persistent immune activation in HLH in many cases. Next slide. And you can see a lot of the genes are described here, perforin, monk, et cetera. There's also a vastly increasing number of gene defects that are being associated with HLH in addition to the known cytotoxic T cell defects. Next slide. And this has first been characterized by a registry study out of Europe. Really showed that patients with primary immune deficiencies also have a high risk of developing HLH, and brings up the question that Michael has discussed in some of our meetings. Well, how can you have HLH without the L? So how can you have lymphocyte activation if you don't have lymphocytes? But I think it really refers more to sort of complex immune disorders that can present with extreme inflammation. Next slide. And there's also a blurring of familial and secondary HLH in that the severity of defect correlates with the timing of disease onset. For example, we have some patients in their 20s and 30s who have perforin mutations, but they're partial defects as opposed to complete defects. Next slide. And there's also immune challenges that can drive HLH. Next slide. And these can include just about, you saw those hundreds of case reports on HLH I showed you earlier. I think just about every pathogen's been associated with HLH in some settings or another. But I think some are more likely to cause HLH than others. So Epstein-Barr virus, for example, is very common. Again, virtually any virus, fungus, or bacteria. Malignancy can drive HLH because the cancer cells stimulate the immune system, but they just don't go away. There can be intrinsic and acquired immune defects. You can have synthetic HLH from CAR T cells or from manipulating checkpoint inhibitors. And then you can also have autoimmune disease, which Ed will talk about briefly. Next slide. And then so a question becomes, like, with all this overlap, how can you tell what's HLH versus what's a physiologic response to infection? So one project I'm going to show just one slide on preliminary data that Michael Jordan and I have been working on is just taking plasma from patients who have HLH and sepsis and trying to see if we can tell the difference just based on their biological profiles. Next slide. And what you can see from this is called a heat map. And you can see the red bits are on the left are healthy children who don't have any inflammation. And on the right, you can see it's a mix of HLH, sepsis, and patients with systemic inflammation. And you can see that's all kind of mixed up. And you wouldn't really be able to tell from this pattern that there's a difference. This represents 135 different plasma cytokines. And how much of each of those cytokines does each patient have? Next slide. But what we can see, I'm sorry, this got mixed up a little bit in a MAC conversion, but what you can see is that there's an interferon gamma signature that's really quite prominent in HLH. And I think that's going to be important when Mike talks about some of the new therapies that we're looking at. So there really is a biological difference between what we call HLH and sepsis or SIRS. Next slide. And I think this bears out in revisiting some data from intensive care clinical trial that looked at anakinra, which blocks IL-1 signaling. There was no difference in survival in those patients, but if you look at the dotted lines on the survival curve, there was a significant difference in patients who basically had some features of HLH. They had hypercoagulability and some other features of HLH. And when they were treated with interferon or with anakinra, there was in fact a difference in survival. And so I think this suggests that maybe even among patients we think have sepsis, there might be differences in risk based on their cytokine profile. Next slide. Malignancy is really a major driver of HLH in adults, much more than kids. And so I think when you have a child who presents with HLH who's been heavily pretreated or an adult, it's important to also consider the fact that cancer might be driving this. Next slide. And then there's a synthetic HLH. I mentioned CAR T cells or some of these other immune manipulators that Ed uses a lot or his colleagues use in CHOP, can also drive HLH. And I think this is something that's having increased awareness. Next slide. And so, again, if you take a group of patients and try to figure out how many of them have genetically inherited HLH versus how many of them we don't have an answer, there's a really interesting study out of Sweden where there were 13 patients who were analyzed, and initially it looked like only half of them had a genetic cause for their HLH. But then when this MUNC13 inversion was discovered, 100% of children in Sweden had an answer for their HLH. Next slide. So we did a similar question here at Texas Children's and asked, out of 100 patients who met criteria for HLH, how many of them meet clinical criteria? Next slide. I'm sorry, how many of them have a genetic cause? And what we found was in that gray piece of the pie, only 20% of them had classic HLH-associated genes. But another significant fraction, over 30%, had primary immune deficiency associated with HLH. And then that purple part of the pie is immune disorder, autoimmune disease, or cancer. And so for only a very small percentage of the patients could we not identify a reason for them to have developed HLH. Next slide. I'm sorry, you can go ahead and skip to the next slide. That one was a duplicate. So I think just to kind of summarize, really, you can develop HLH because you're born with a really severe genetic defect that your immune system is predisposed to HLH. Or I think if all of us were exposed to Ebola virus, we'd probably meet some kind of clinical criteria for HLH. And the question is, how much is intrinsic, how much is acquired? And so what kind of therapy is required depending where you are on that spectrum? Next slide. And I think nomenclature is something that we're really working on. My bias is to say that you have pathologic inflammation due to X, and it's really up to us to figure out, to solve for X. Is it an inherent gene defect? Do you have a trigger, et cetera? Because I think it's becoming a much, much more complex environment than we envisioned maybe 5 or 10 years ago. Next slide. All right, so I think our ultimate goal is to figure out for you and your child, really, why do you have HLH and what can we do to dismantle it to restore your immune system to normal function? And I think with that, I think that's my last slide. I'll hand over to Mike, who will talk a little bit about the kind of some really new exciting therapies that we have to approach patients with HLH.
All right. Okay. So, hi everybody. I'm Mike Jordan at Cincinnati Children's. So let's go on to the next slide. And so I'm going to talk about treatment for HLH, and I'll try to be fairly, I'd say, concrete and practical throughout this. So I'll talk about conventional therapy. I'll talk about targeted therapies, talk about experimental therapies, and then a little bit about some kind of miscellaneous things as well. I'll have a brief word about BMT that almost deserves its own discussion, but I think we can't talk about therapy without at least bringing it up. And then finally, I think, one of the important things, I think perhaps some of this is, may already be apparent from what Carl has already said, is that, some really important determinants of patient outcomes ultimately have little or nothing to do with the choice of therapy. So what I'm referring to is the fact that making a prompt and accurate diagnosis is really critical. Carefully monitoring of response to therapy is very important. Proper supportive care, and then finally sort of being very proactive in terms of preparing for bone marrow transplant are really important ultimately for patient outcomes, but are not directly tied to any particular therapy. So next slide. So in terms of HLH, really I want to talk about kind of what's the context that we're talking about and what are the goals of therapy. And so as you might imagine, all patients with HLH, when they present, are kind of like a house on fire, right? There's a tremendous amount of inflammation, and it needs to be cooled down, and the process needs to be halted. But ultimately, the reason for doing that is so that somebody can get to bone marrow transplant in order for a long-term cure. So next, and there's a few little things here about the history. So it's been a long path, you might say. The initial report of what's sort of the basis of standard therapy, that is this drug called etoposide, was back in 1980, now almost 40 years ago. And then eventually followed by organized international trials, and then moving into more of a targeted era more recently. Transplantation itself was sort of, the development of transplantation has occurred sort of concurrently as well. So next, the basic goal here, right, is that all of these different therapies, regardless of what type we're referring to, is really to try to control the HLH. And then the purpose of transplantation is really to prevent it from coming back in order to effect a long-term cure. So next slide. So in terms of conventional therapy, this is sort of a diagram describing what I think most people in the world would describe as sort of the standard sort of approach for treating HLH. And that patients are treated with a chemotherapy agent called etoposide, initially rather frequently, but then sort of spacing it out as you move forward. Also with relatively strong, not extreme certainly, but strong doses of a corticosteroid called dexamethasone that is sort of stepped down over the course of about 2 months. Additionally, if patients need it, if they have inflammation in the brain, then they also may receive intrathecal therapies listed here as intrathecal methotrexate and hydrocortisone. So next slide. And so the outcome using standard therapy is demonstrated here in terms of long-term follow-up. And so as I mentioned, this is a product of many years of study, initially with a study from the Histiocytosis Society starting in 1994, with a follow-up study in 2004. This is actually the follow-up from the very long-term follow-up from the HLH-94 study. As you can see, 64% of patients are long-term survivors. In this study, about half of patients underwent bone marrow transplant. The follow-up study a decade later showed a very similar result, a little disappointing, but I think demonstrating that there is a large portion of patients with HLH that are extremely difficult to treat. So next slide. So let's move on to more recent, you might say more modern targeted therapies. So based on experimental work from really starting almost 20 years ago, it was recognized that interferon gamma is a really important mediator in HLH, as a really important sort of driver of the disease process. And so a drug called emapalumab, which is a monoclonal antibody targeting this cytokine, was developed, and a clinical trial was conducted. Actually, I should say a few clinical trials have been or are being conducted. And the drug was approved by the FDA at the end of 2018 for the treatment of HLH after patients had sort of been through other therapies. So another way to think about this is sort of second-line therapy. The first-line therapies either didn't work well or they didn't continue to work well. And so moving on to sort of option B, is what this drug is really approved for. There is an ongoing international, actually more than one ongoing international study, one to assess its usefulness as the initial therapy for HLH, so upfront, and then a different study to assess the utility of emapalumab in macrophage activation syndrome, which is a version, I would say, of HLH that occurs in the context, in this case, of juvenile idiopathic arthritis. So next slide. So the response to emapalumab in the pivotal HLH trial is shown here. So we recently published this. So next, you can see that about almost 2/3 of patients displayed evidence of response. Again, I think demonstrating the fair bit, there's a hard core, you might say, of patients that remain rather difficult to treat. And there's some variability in terms of how patients respond. But the majority of patients did have evidence of one degree or another of response. And so we were encouraged because remember, these were mostly patients treated in second line. The two bars are, the lighter color is the patients that were sort of previously treated on the trial. It was 27 patients. And the darker color is actually all of the patients on the trial. So it includes some patients that received the drug as their initial therapy for HLH. And the two groups, even though this, so the two ways to slice this look pretty similar, though admittedly there's only a very few patients in this trial that received this drug as their initial therapy of HLH. So next, one of the lessons that we learned is that if the drug hits its target well, then the patients are more likely to respond better. And that's just a way of interpreting this graph here. So measuring CXCL9 is one way to determine whether or not the interferon has all been blocked. And as you can see, as the CXCL9 levels go up, in this case, this is a log transformed axis, the likelihood of actually responding by the end of treatment actually goes down. So in other words, if the drug isn't adequate to really block interferon gamma, it's not as likely to actually be effective. So next slide. Survival in this trial was very encouraging. So on the left is the patients that were previously treated, which we have reason to believe are actually selecting for some of the most difficult patients with HLH. On the right-hand side is all the patients in the trial, again, most of which were previously treated. But you can see the longer-term survival, in this case, getting close to 2 years, but not as long-term as the slide I showed you for the standard therapies, is in the 70 to 75% range. So, so I think that we found this to be a very encouraging survival. So next slide. So what about experimental therapies that are currently being tested in the context of clinical trials that I think is best described as sort of, you might say, emerging therapies that I would not call certainly standard yet by any means. So next, so the first one is inhibition of cytokine signaling. So inhibition of signaling by interferon itself, as well as other cytokines using drugs called JAK inhibitors. There are a variety of these drugs that have been approved or are being investigated for approval in different diseases. And actually, Dr. Hines will talk about an upcoming trial testing one of these, so I won't touch on that any further. But another emerging therapy is blockade of IL-18 using a drug called tadakinic alpha, which is a IL-18 binding protein, which may be particularly useful for certain subsets of patients with HLH. So next slide. So also, I'd be remiss if I didn't bring up other therapies. As you might imagine, this is a syndrome that's been treated over the years without, for much of that time, without any sort of sense of what is truly standard therapy. And no drug, at least until emapalumab, was ever actually approved by the FDA or any other regulatory authority for the treatment of this disorder. So a variety of approaches have developed, and so they're listed here. So these are approaches that definitely have some useful clinical experience. The data compared to things such as etoposide or emapalumab are definitely more limited, but they are as follows here. So pulse dose corticosteroids. So these are essentially not the sort of doses that most heme-onc docs treat HLH with, but very, very high doses. And this has mostly been utilized in MAS, and rheumatologists are all very familiar with utilizing this approach. It also appears to have some real utility in classic HLH as well. Alemtuzumab, which is an antibody that depletes T and B cells. And there is good experience with this drug in second line. And there's in fact actually also an ongoing trial in France to assess its use as a first-line agent. Anakinra, which I think Dr. Allen already kind of referred to, is a drug that specifically blocks IL-1. There's relatively limited data in patients with sort of classic HLH, but it's used in many patients with MAS. So next slide. So how do we think about these different therapies? So I like to go back to sort of how does the disease develop, and what context do we sort of map out where these different drugs are working. So if you think about this disease is being driven by T cells, mediated by interferon gamma, and executed in large part through the misbehavior of macrophages. When something in patients with HLH, when something turns on the immune system and eventually leading to HLH, we can intervene, we can try to block things in a few ways. So the more conventional therapies are on top. So corticosteroids act really broadly to try to suppress activation of macrophages, suppress activation of T cells. Etoposide very specifically appears to be very efficient at killing activated T cells. And of course, drugs like alemtuzumab, but also another drug called ATG, which are specifically target T cells, are aimed at T cells. But in terms of more newer, more targeted agents, of course, we can block interferon itself. We can block the signaling of interferon in sort of target cells using agents like JAK inhibitors. And then there are additional agents that block specific cytokines that may be contributing to the syndrome in specific patients. Cytokines such as IL-1, IL-18, or IL-6. So next slide. Next slide, please. And then a word about bone marrow transplant. So survival of patients through bone marrow transplant historically has been relatively poor, but starting in I would say the early 2000s, initially pioneered by the Great Ormond Street Hospital in London, and then taken up by us in Cincinnati. It was this approach to try to utilize reduced intensity conditioning transplantation. This has been further developed by a cooperative group in the U.S., the BMT-CTN, and led by Dr. Allen, a study essentially taking this approach and applying it across many different centers. And what they found was that survival post-transplant was really quite good, similar to what we had seen and what Great Ormond Street had seen as well. But there still are major challenges, and that is trying to maintain the graft in these patients. Is actually a real challenge. So on the right is the incidence of intervention-free engraftment. You can see more than half, or approximately, maybe you might say approximately half of patients really had difficulty maintaining the graft. And of course, the graft is what prevents HLH from coming back. So I think there's still a lot to be learned here, but certainly progress has been made. So next slide. Yes. So at this point, I will turn things over to Dr. Behrens.
Great. So I actually don't have any prepared slides because I was sort of given, in some sense, the catch-all topic of MAS, COVID, and Miss C. So I thought maybe I'd just do this a little bit more conversationally, and I saw that there were a couple of questions in the chat, and I'll try and get to them as well. So actually both Carl and Mike did a fantastic job, setting me up almost to the extent that I don't actually have much to say. I think, Carl kind of touched on the nomenclature aspect of this, and I think that sometimes the words that we're using for these syndromes are getting in the way of everybody's understanding, and that patients and physicians. And I couldn't agree with him more that we just need to dump the whole shebang and just start calling these, whatever you want to call it, hyperinflammatory syndrome, or I forget exactly the language that he used, but that same idea. So to that extent, philosophically, I'm not sure that I make much distinction between MAS or HLH or any one of a number of the other names that these things have been called. I think that this represents a common state of an immune system that's overdriven, out of control, and resulting in all of the symptoms and signs that you just heard about from the previous two speakers. Historically, MAS is the term that's been used by rheumatologists to describe this phenomenon. HLH is a term that's been used by oncologists to describe this phenomenon. And I think we're both describing the same zebra, unicorn, horses described as zebras when we're using those words. So hopefully in the upcoming years, the language that we use gets better so that we all can just sort of recognize we're talking about the same thing. I think the other thing that happens, and I think it's been brought up because, you know, we're all seeing the same thing from different perspectives. We each have our own different hammers. And when you have a hammer, you smack the nail that's in front of you. And the rheumatologist hammer is, as was mentioned, pulse dose corticosteroids, cytokine blockade, typically in the form of IL-1. And, you know, I think that those hammers tend to work for our patients. Typically, we're seeing this in the form of disease after systemic juvenile idiopathic arthritis. You know, and I think there's a good experience for it in that setting. And, you know, we're not treating as much the perforin deficient patients. And as Mike pointed out, there's very little data for those interventions for that disease. You know, conversely, oncologists have their sort of proven tried and true for the perforin deficient patients and some of these other related conditions, and certainly works there. And, you know, may or may not work in rheumatologic conditions, and may or may not be overkill in rheumatologic conditions. And I think that's the area of debate. And I think getting past the sort of nomenclature and getting to the point of just saying, look, we're all talking about the same thing. How can we learn how to most effectively treat this same thing when it presents itself in these different settings? Or, you know, as Carl put it, the personalized medicine approach is really where we're heading. I think the other thing I would just say about the subject is philosophically, you know, once you kind of get your mind in that mindset, you know, I think you're able to see the same process playing out in all these different settings. You know, what you begin to recognize is the different corner cases, the different settings where the paradigms don't quite fit. So there's without a doubt, you know, the central role for interferon gamma in HLH and even in MAS. And yet, as Mike pointed out, there are some patients that don't seem to be responding to interferon gamma blockade, you know, maybe as salvage therapy, we'll need to learn about as frontline therapy. You know, there are certainly patients, you know, in the rheumatologic world that present with what looks like MAS, but don't have the interferon gamma signature. And so there's probably a bigger tent, you know, for a whole host of different settings that ultimately present itself in this MAS, HLH, like presentation, but aren't necessarily even interferon gamma driven. And so continuing to explore other options for therapies, I think, is the other place that we, you know, need to go in terms of precision medicine. So there's been a lot of talk about COVID-19, MIS-C, SARS-CoV-2. This has, you know, without a doubt been a life-changing experience for everybody. I guess, you know, of the folks that are on the call, you know, practicing medicine in Philadelphia, we perhaps caught the first wave of it. I think it's certainly now, you know, full blown in Texas and is reaching other areas of the country as well. But having sort of lived through that first wave, you know, March onward here in Philadelphia, our team has had the opportunity to try and do some investigative work to try and understand how SARS-CoV-2, the virus that causes COVID-19, causes illness in children. So I saw that there was a question about SARS-CoV-2 infection in HLH. I don't know that I have all the data. I am aware of one child that seemed to be their presenting trigger, the SARS-CoV-2 infection, who ended up having a genetic diagnosis of HLH. I don't think that makes SARS-CoV-2 special. I think that there are plenty of viruses that can trigger HLH, and so that just happened to be that child's trigger. One would think that given the number of children that have experienced an infection, if it was really an outsized signal, we'd be seeing a lot more of it. So I don't know that the virus itself presents a special HLH risk. And if Mike and Carl have more information on that, you know, they can certainly jump in, you know, at the end as well. But that's been my impression. The good news is that in general, COVID-19 infection in children seems to be a relatively mild event. Most kids, if you're otherwise normal and healthy, don't experience that severe COVID-19 pulmonary syndrome that many older folks seem to be getting. The one thing that did sort of take us by surprise was this MIS-C diagnosis. So this was all over the news for a while. Children that are getting this so-called Kawasaki's-like syndrome after SARS-CoV-2 infection. Kawasaki's disease is another sort of mysterious rheumatologic inflammatory disease of the blood vessels of the heart. No one knows what causes Kawasaki's disease. Many people think it might be a post-infectious process. Excuse me. And there was sort of this initial recognition that perhaps we were seeing more of it in the COVID-19 era. But I think as we got more sophisticated in actually seeing what was going on, what we realized is that children were indeed presenting with this thing called MIS-C, but it was, while it had some overlap with Kawasaki's disease, it's actually something quite different. So unlike Kawasaki's disease, which is more coronary artery directed, MIS-C seems to be more about the ventricles of the heart. The muscle of the heart itself seems to get inflamed and stop working. These children also seem to have a severe gastrointestinal inflammation, and they present with severe dehydration and shock. And fortunately, the vast majority of them get better with steroids and IVIG, sort of minimal therapy. Certainly, they get a lot of supportive therapy in the intensive care to support them while those medicines are kicking in. But universally, our experience at CHOP is every single one of our cases have gotten better with this therapy, and basically are back to normal health. We don't know why children are getting MIS-C. We're actively trying to research that. There seems to be a particular cytokine pattern, which is actually not interferon gamma. It's a different set of cytokines. IL-10 and TNF-alpha seem to be the ones most associated with MIS-C. Some of these children do have very high interferon gamma, but some of them don't. And so, we don't know what the fact that that's sort of spotty means. We're trying to figure out whether these are two different groups or not. We're doing a number of different investigations into the immunology of this to try and understand it. It's really still too early to make any definitive statements. But I think between ourselves and centers in New York and centers at Boston that have seen a lot of these patients, you're going to be seeing a lot of answers soon. There's been a lot of lay press about SARS-CoV-2 and cytokine storm. Is it a cytokine storm? Is it not a cytokine storm? Is it like HLH? What's going on? It's probably worth just sort of touching on that for a second. Cytokine storm, again, is another one of these sort of vague terms. And basically, again, refers to an out of control immune system associated with elevations in cytokines in the blood. To that extent, maybe there is an element of cytokine storm to MIS-C. Maybe there's an element of cytokine storm even to COVID-19. But I don't know that it's special in any way, as opposed to a number of different infectious cytokine storms that we've dealt with all along. Influenza could certainly be considered a cytokine storm in the right context. A whole host of different viruses. Adenovirus can cause a cytokine storm in the right context. What I think we can clearly say it's not is it's not HLH. It does not have the signs and symptoms of HLH. It does not look like HLH. And so I think there was a lot of questions and concern, I think, in one of the previous town halls that we did about this relationship between SARS-CoV-2 and HLH. I just think there's no relationship outside of the fact that it's a virus, and like any other virus can be a potential trigger for HLH, but it's not special in that regards. And so, yes, it's a disease of the immune system and an overactive immune system. And so in that way it might be a cytokine storm, but I don't think it in any other way bears a relationship to HLH. So, it's early days in the immunologic research. We're learning more. And I think, perhaps, in another town hall, when we have more information, I could certainly present some of those data. I guess the only other thing that, since I was sort of looking at the questions and looking at the chat, somebody asked about DR positivity in T cells and emapalumab. I don't know if Mike has those data. I would say anecdotally at CHOP, in the few cases where we've used it and checked, we can actually show that, not surprisingly, DR goes down. since it is an interferon gamma regulated gene, but we've not studied it in any coordinated way. I'll let Mike address that later on if there's actually more formal data sort of looking at that. So with that, I think I'll stop there. I'll turn it over to Melissa to discuss the Ruxolitinib trial.
Okay. Am I going to be able to share my screen, or are you guys going to go through the slides for me?
We can drive for you, Melissa.
Okay, we'll see how it works. So yes, I'm Melissa, and similar to Mike, I'm using a flame to describe HLH. And I just wanted to go through just very briefly the upcoming HLH Ruxo trial for using Ruxolitinib for HLH. Okay, next slide. I did want to give a special thanks to the Histiocytosis Association. We actually did get a grant from the HA for support of running this trial, so thank you. Moving on, next slide. So as has been described by everybody else in the group, we know that many different cytokines are involved and are elevated in HLH patients, with the most famous or infamous being interferon gamma. That by controlling these cytokines, that seems like a really good idea for therapy. If you could hit the next slide for me. Oh, go back. Okay. Yeah, there's stuff that shows up. That's why I wanted to control them. Anyway, so because we know that cytokines are actually one of the biggest things that causes symptoms in HLH, and they do spur on continued immune cell activation. So they're a good target for new therapies. So next slide. So that's where the idea came for repurposing a drug called Ruxolitinib for treatment of HLH. And Ruxolitinib is a JAK1/2 inhibitor, and that is a very complicated way to say it pretty much inhibits the majority of cytokine signaling. So if you could click the button again, yeah. So it inhibits multiple cytokines. They're important for the development and continuation of symptoms of HLH, including interferon gamma. Next. One of the nice things that we found about Ruxolitinib whenever we are looking for an agent is just how easy is it going to be to give the drug. And one of the things that made it attractive is the fact that it was an oral agent. Next. And that it has a relatively short half-life. So when the drug is stopped, the effect of the drug goes away fairly quickly. Next slide, next. And the other nice thing about it is that this particular drug is FDA approved for other indications, so for other diseases. And so we had an idea going into the trial when we were making the trial what types of side effects we would be seeing and could plan for those potential side effects and know what to look out for. Next slide.
Dr. Hines, if you want to try to control screen, I should have passed it over to you.
Oh, it still says host disabled. Maybe I'm in there as an attendee. It's okay.
Okay.
So where does Ruxolitinib fit into the treatment of HLH? And Mike showed this very beautifully a minute ago. So if you could click, yep. So conventional therapies such as etoposide and steroids really do target the immune cells that get activated. And similar to imipalimab, if you hit the next for me, Ruxolitinib would be affecting at the level of the cytokines and inhibition of those. So the goals of the HLH Ruxo trial really is similar to any other trial for HLH, which is we know that 5-year survival is not great, and we do know that there's significant mortality that happens within the first 8 weeks of therapy based on the HLH 2004 trial. Next. And so really we want to improve survival of these patients, but we would like to do so with less toxicity than what we've seen with previous therapies, such as etoposide, for example. And so within our trial, because it's response adaptive, what we're doing is we're starting with ruxolitinib, which we're hoping is going to be less toxic than the previous therapies, such as etoposide, and then add more therapy if needed based on what the patient needs or the response of that patient. Next slide. So we're actually going to be looking at 2 different types of patients, similar to the emapalumab trial, where we'll be looking at using ruxolitinib in newly diagnosed HLH patients that have never seen therapy before, and we're calling those the frontline patients. And then we're also going to be looking at patients, looking at ruxolitinib in patients that have received previous therapy, or called salvage patients or refractory or relapse patients. So we're going to be offering it to both groups of patients and looking at them separately. Next slide. And so what is this protocol going to look like? So if you click to the next, so we're looking at enrolling about 62 patients, and all patients will initially be started at the beginning on ruxolitinib and dexamethasone. And next. And if they look like they're doing great through therapy, then they will be continued only on ruxolitinib and dexamethasone for the 8 weeks of therapy. But if they do not look like they're doing very well at the beginning, like they still are showing signs of active disease, then at that point we would add etoposide. So there's a chance that patients, depending on how they respond, will receive all 3 drugs. And if they do well, then they'll be followed out for the entire year. And then if they do not do well, then they'll be taken off the trial, off treatment, and we'll try other therapies for those patients. And so the big endpoints that we're looking at for the trial is how are they going to respond to this therapy, particularly at 8 weeks, and then we'll be looking at overall survival for the year and following them up, and how many patients go to transplant and things like that. Next slide. So we have a total of 10 sites that we are looking at opening this trial right now, and they're all part of the North American Consortium of Histiocytosis, or NACHO, which is a consortium or group of hospitals that help run clinical trials for histiocytic diseases in North America. So that would be Canada and the United States, but these are our current sites for this trial that we've selected. Next slide. And so where are we right now, and when is this trial going to open? So as of now, if you just click next, thank you. We are working on the IRB approval process at St. Jude and finishing up everything at St. Jude right now. And we're hoping to get everything approved and start enrolling patients potentially in the fall of this year, and then moving to open the trial at other sites with enrollment by spring of 2021. And looking to complete the trial by 2026. Next slide. And here is our lovely team. Kim Nichols is my partner in crime and my co-PI for the study, and she's the one that's done all of the preclinical data on the previous models that have shown that this looks like it could be an effective therapy for HLH, and why we've moved forward to trying this in patients. And then next slide. And with that, I will go to the Q&A for the group.
Thank you, Dr. Hines, appreciate it. And thank you to all of our doctors for your time today. We do have some questions, and I know some have been addressed. So I'll go through the ones that it looks like haven't been touched on yet. There was a question about emapalumab and if it was for all age groups.
Yes, yeah, it's approved actually for both children and adults.
Great, thank you. And another question we have is, to what extent has there been tracking of children who are determined to have genetic form of HLH but have not yet triggered the disease itself?
I'm happy to take that. So that would typically only happen or if a sibling or family member had HLH, and that would then kind of lead to exploring family members' genetic status. And I think there's some debate as to whether you would go ahead and transplant a patient before they've had any symptoms. Certainly these patients merit very, very close follow-up, and it really depends on the genetic defect. I mean, if there's complete absence of perforin, for example, I mean, you can predict with I'd say almost 100% certainty they're going to develop life-threatening disease by the time they're 1 or so. And so there are some cases where children are transplanted before they're symptomatic. But I would say that's just sort of a bit of a complex question that requires, I think, multidisciplinary discussion with immunology, geneticists, BMT team, and also centers that are kind of familiar with this syndrome. And I'm not sure, Mike, if you can comment on cases that you've dealt with at Cincinnati that fall under this umbrella.
Mm-hmm. Yeah, it's a complicated issue, and you know, what it comes down to is to what extent does that specific genetic abnormality sort of predict the future? And there are some cases where we know that we can't predict the future very well at all, and there are others where we know that we have really high confidence, as you mentioned, Carl. But then there's a lot that are sort of in between. So unfortunately, there are still situations where we have to sort of follow the child and with some degree of uncertainty about kind of, you know, what the future is going to hold for them. And it can't be more specific than that. It depends on, like I said, the details of the specific genetic issue.
Okay, thank you. Another question we have is, if there has been no known trigger found, is there any testing that can be done to figure out a trigger of secondary HLH?
Yeah, I'm happy to start with that. That question is sort of what drove our study where we did whole exome sequencing on patients who met clinical criteria for HLH, but you know, we didn't find a gene with conventional targeted sequencing of the cytotoxic gene defects. And the personal bias of our institution is that anyone, I hesitate to make broad sweeping generalizations, but I would say the vast majority of patients who meet clinical criteria for HLH will try to find, to do comprehensive genetic testing, meaning whole exome sequencing and chromosome microarray testing, just because there's so many different genetic variants that are associated with immune dysregulation that are now being associated with HLH. And I think our ability to detect these variants is much greater now. I think whole exome sequencing has decreased from $10,000 to maybe $1,000 depending on institution. There's also some broader targeted sequencing panels. So I think that would be number one. And the second thing would be if someone shows up with a long history of immune suppression. I think as you wean the immune suppression, it's important to look out for reemergence of autoimmune disease, occult infections, or malignancy. And so again, I think it takes a really multidisciplinary approach of people who are willing to kind of dive deep to turn over every stone. And every once in a while, you don't find an answer, and just based on the severity of the disease, have to make a decision about attempting to do transplant or continue long-term immune suppression.
And maybe I'll just throw in my half a cent, because I kind of want to say it maybe even a little bit stronger than what Carl said, because I think it's an advocacy issue. I don't think it's just Carl's personal opinion. I think every child that's had an event of secondary HLH that had negative screening of those primary HLH genes deserves whole exome sequencing and a genetic workup. So as an advocacy issue, we should not be allowing insurance companies to say, no, we're not going to pay for it. I think that is every child that has that deserves that look for the exact reason that Dr. Allen outlined, which is that you are often going to find something, and you often find something that informs therapy. So I think we should be strongly just making the blanket statement that people deserve that kind of a workup in this scenario.
Great, thank you. I think we have time for maybe 2 more questions. One question, there's a background about a family has two children and one had HLH. Questions really are around sort of the sibling of the patient. Are there studies around adult siblings of pediatric cases presenting with HLH? And a question along with that was posed was, what survivor studies are being done to track after effects of the HLH-94 protocol? So I know they're a little different, but same person asked those questions.
There is an ongoing effort to look at long-term outcomes. It's through bone marrow transplant registries, principally. So it's not entirely tied to HLH-94 or 2004 approach, but there is an effort through the Histiocyte Society to look at long-term outcomes. And there have been some papers published in the area. I think there's still plenty to learn, though, of course, because as you can probably gather, what we're doing for these patients is certainly continues to evolve. And in terms of any more, specific comment to adults, say with other siblings that have had HLH, there certainly are examples of patients developing familial HLH as an adult. And it may in fact be tied to certain mutations that are perhaps a bit milder than the ones that we typically see in infancy. So I would say, as a general statement, it's a concern. It's a potential concern, depending on the specifics of the situation.
Thank you. And Dr. Hines, this question may be passed to you, and anyone else can jump in as well. What would you like to think of Jakafi for SIGA MAS patient 1 of treatment option?
Say that again.
Sure. So the question is, what would you think of Jakafi for SJIA and MAS patient treatment options?
So I think that it is a potential therapeutic option, but we are not going to be studying that in HLH-Ruxo. We feel like those patients are very different than the general kind of primary HLH and some of the secondary HLH patients. So those are not patients that we'll be studying in HLH-Ruxo. But I do think in the future, especially if patients do really, really, really well with emapalumab, that we could start looking at JAK inhibition for refractory MAS and things like that. So I think it remains to be seen, but it is a potential therapeutic option. Anybody else have anything to say?
Yeah, maybe I'll just jump in too, right? So there's an ongoing trial, right? So there's an active clinical trial. It might not be Ruxolitinib. It might be a different JAK.
It may be
either tofacitinib.
Yeah.
There's also a dapirolizumab trial as well. So there's a couple of JAK inhibitor trials in JIA and systemic JIA in specific. So for the question of plain old, uncomplicated systemic JIA, it's an active research question for which we don't have the answer. For the question which I think is really being asked in a patient with refractory MAS, chronic MAS, and systemic JIA, is it a viable treatment option? Again, we don't have large-scale clinical trials to guide us, nor are we likely to have those trials anytime soon. I think we're obviously it's being started in HLH, but it's certainly a treatment option that has been anecdotally used by a number of different folks. And so there's, at least at the anecdotal level, some positive reports that it's useful. I think ultimately, when you're in that space of being, a rare population of a rare population, right? Because systemic JIA is already rare, and now we're talking about a population of patients that are even rarer. It really becomes sort of a personal discussion between you and your physician, who knows you best, who probably already knows what medicines you've been on and have failed, and have gotten you to the point where you're reaching a discussion around something like Jakafi.
So to clarify, you're saying that at this point you would say it's for refractory patients.
I think, in systemic JIA MAS, we don't quite, unfortunately, have a protocol like HLH-04 that has been, put to the test in the same way, but there's certainly decades of experience using pulse steroids, using IL-1 blockade, and you know, often that as a front line is able to get patients under control, and using cyclosporin, I should say, or tacrolimus. And then I think, you know, if you're failing those medicines, that's when you're reaching for something like a JAK inhibitor at this point in time.
Thank you. If you have time for one more question, we might have the ability to answer one more, and then I think what we'll do is we'll take down all of the questions and try to respond to them and send out a Q&A to all of the participants. The last question we'll ask is, what is a partial mutation versus a full mutation, and can you provide an example?
So thank you for that question. I'm sorry I wasn't more clear. So in some cases, you can have a gene defect that results in complete absence of a protein, such as perforin. In other cases, you might make, the gene defect might make some protein, but it just doesn't work as well. So it's sort of the, you know, difference between riding a bike on a flat tire versus not having a tire. And so I think the severity, when we talk about the severity of the gene defect, it means what are the biological implications of that genetic change.
Great, thank you so much. And thank you everyone for holding on with us. I know we're a little past time, so we'll wrap up fairly quickly. But I just do want to say thank you to Dr. Jordan, Dr. Allen, Dr. Behrens, Dr. Hines. We really appreciate your time today. This has been fantastic. And as I mentioned, we will go through all of the questions that are still there and try to respond to all of them in a Q&A leave behind for everyone after the webinar. So I just want to really quickly highlight a couple of resources that the association has available for you. We do have a COVID-19 hub on our website if you'd like to check that out. It includes some links that around COVID-19 news from the CDC, some medical articles related to histiocytic disorders from reputable sources, and some resources as well. You can also get involved with us if you are staying safe at home and would like to get involved in the Histio Open stage. You can find some performances from some of our warriors there on Facebook and our website and submit your own as well. And I also want to direct everyone to the Histio resource directory. You can find that at histio.org under Explore Resources. And you can come here to inform, empower, connect. This is what we use this place for the members of our rare community, sharing knowledge and resources that will make this journey a little easier. With the help of volunteers in the Histio community, we have compiled an extensive list of resources at the state, national, and global levels. So you can find that directory, like I mentioned, at visiting histio.org and selecting Explore Resources. We also just wanted to share some upcoming events. The successful work done by the association is a direct result of the collaborative nature of this community and the desire and willingness of everyone to get involved in their own way. From connecting with one another to organizing fundraising campaigns and events and donating in support of the association, there are limitless opportunities to make a difference in the lives of patients with histiocytic disorders. Here are a few that are happening in the coming weeks. We have a trivia night on the 30th, a golf tournament on the 3rd of August. September is our Histio Awareness Month, and during that month we also have a camp out. So be sure to check out our website for more information, or join online on our website to receive email updates and news and things of that nature. There are also some ways to support. Everyone's been ordering more through Amazon recently, so when you check out, shop through Amazon Smile, where you can select a charity of choice to give back a portion of your purchase to the association, or you can make a donation directly through our website. And then if you'd like to stay connected with us, let us know. You can reach out to us at outreach@histio.org to stay connected. You can find us on a variety of different social media and social channels. And we, again, just want to say thank you so much to our amazing panelists, Dr. Allen, Dr. Behrens, Dr. Hines, and Dr. Jordan. Thank you to the team at the Histiocytosis Association for helping to facilitate this webinar. And thank you all for your time today. Know that we will continue this conversation as we need to, and we encourage you to reach out to us if you have any questions because of today or after today. Wishing you all good health. Thank you, and have a wonderful afternoon.